which is about the progress made towards the achievement of the milestones and goals which are included in the global NTD roadmap with regards to the subgroup of neglected tropical diseases, which are those who can be controlled or eliminated through preventive chemotherapy, which is a large-scale administration of drugs to entire population groups. So I've divided the presentation in three parts. The first part is a kind of global framework to tell you what are the norms and the background documents that support the control and elimination of this group of neglected tropical diseases. Then I will talk about a few updates, disease-specific updates, and in the end, it's mainly about the progress in terms of coverage. So the most important and most recent background document that we use in order to justify the implementation of preventive chemotherapy interventions is one very recent WHO World Health Assembly resolution 66.12 that was adopted last year by the World Health Assembly in Geneva. And the key aspect, the key factor, which is the key characteristic of this resolution is the fact that for the first time in history it addresses all neglected tropical diseases together. In the past, you might know that all these diseases were addressed individually, and therefore I would say there was a lot of wastage of resources because of course we had to implement disease-specific interventions here and there. Now, since 2006, 2005, the objective is trying to integrate the fight against neglected tropical disease. So after a few years, the World Health Assembly decided to adopt this resolution that supports basically is the way through which member states commit themselves towards the implementation of interventions aimed at controlling, eliminating, or eradicating NTDs. One aspect of resolution 66.12 is that it endorsed the WHO roadmap, which is this document here. That is a short document that basically puts together all the diseases and provides milestones and targets toward the achievement of disease-specific goals. So it's a document that gathers together all the diseases and provides clear objectives that member states should achieve in order to comply with international norms, which have been also endorsed by the World Health Assembly resolution, which is the highest body, let's say, and the most authoritative document. Now let's have a look at what it says with regard to the diseases I'm talking about, which I repeat myself, are those which can be controlled or eliminated through preventive chemotherapy, mass drug administration, to be simpler, which are lymphatic filariasis, onchocerciasis, schistosomiasis, soil-transmitted hepatitis, and trachoma in a way. So you see that the first effort was to try to standardize the endpoints of the interventions that are recommended for implementation. So you see, for example, we have eradication, which means the global interruption of transmission, but the diseases we're talking about, for the time being, none of them is slated for eradication. Then we have diseases which are candidate for elimination, which are lymphatic filariasis and blinding trachoma. I have to say that for the time being, the resolution talked about elimination as a public health problem, which means not interruption of transmission, but the decrease of transmission and the decrease of morbidity below certain thresholds that have been set. Then we have a bit less ambitious goals, regional elimination. For example, onchocerciasis, as you know, for the time being, is slated for elimination in the Americas. In Africa, it's still control of morbidity largely, even though now the regional program is willing and committed to shift from control of morbidity to elimination. And then we have also, elimination is also relevant to schistosomiasis, as Alan was explaining before. In 2012, a resolution that was promoted by the government of the Kingdom of Morocco requested the other countries, including of course themselves, to support a resolution that supported the evolution from control of morbidity to interruption of transmission of schistosomiasis. So the roadmap was the occasion to try to differentiate the different schistosomiasis landscape and scenarios, and therefore it included, for example, the elimination, defined as interruption of transmission in the Eastern Mediterranean and in other countries. Sorry, in other parts of the world. I think this is not going to be achieved because unfortunately in the Eastern Mediterranean we still have high endemic countries, especially Sudan, which is of course is part of Africa, but from a WHO perspective is in the Eastern Mediterranean region. While things are going very well in Yemen with the support of SCI, even though perhaps interruption of transmission will not be achieved by 2050. Schistosomiasis is also slated for elimination in the Americas and in the Western Pacific, where transmission has been decreasing significantly over the past few years, especially in Cambodia and Laos, while it remains significantly high in the Philippines and fairly well controlled in China, but perhaps we still need to invest more in order to achieve interruption of transmission by 2020. I was mentioning Yemen, country elimination. In principle, it should be achieved. Country elimination of onchocerciasis in Yemen should be achieved by 2015. Perhaps it won't be achieved as well. But now things are moving in Yemen, luckily enough, piggybacking on the schistosomiasis control, the Yemen schistosomiasis control project. It is supported by the World Bank, with the support of SCI. So building up on the network and the structure of the schistosomiasis project is supported by the World Bank with a very generous grant of $25 million. Hopefully, onchocerciasis will also be controlled first and eliminated later. And then, of course, also in selected countries in Africa, both onchocerciasis and schistosomiasis. The disease that is left out is soil-transmitted helminthiasis, which are the intestinal worms, whose transmission rates are usually very high in the environment, also because they have a relatively simple transmission cycle compared to the other diseases that require vectors. And therefore, for the time being, the objective is control of mobility. So disease-specific stages. So I'm going to present a brief update on each of the diseases. The first one is lymphatic filariasis. As I said before, it's a disease that is candidate for elimination. The resolution says elimination as a public health problem. Discussions are ongoing whether we should keep this definition of elimination as a public health problem or go as elimination to poor, which would imply interruption of transmission globally. Probably the more conservative definition is the one that's going to be adopted. Being an elimination program, it has a fairly developed and fine system of monitoring evaluation. So the focus not only on scaling up, which means scaling up coverage of the drugs that are distributed, but also trying to scale down where the objectives are achieved. And therefore, you see here the first bullet point. We have a quite good number of countries, for example, 13 here, as of June 2014, which are under post-NPA surveillance, which means that the transmission conditions are sufficiently good, transmission is sufficiently low to enable the programs to stop NDA and start surveillance. A good thing, very recent, there's a long-term commitment by GSK to provide albendazole and by Merck to provide ivermectin, which the two drugs are combined, are co-administered to eliminate LF in countries which are also endemic for onco, mainly Africa. But for all the countries where onco is not endemic, the ethyl carbamazine is the first line treatment together with albendazole. So WHO managed to negotiate the position from Eisai, which is a Japanese company, in order to provide drugs. And therefore, we can now say that all the drugs which are required to eliminate LF globally are available. So albendazole from GSK, ivermectin from Merck US, and DC from Eisai. There is several normative things which have been ongoing, documents which have been developed in order to provide clear recommendations on the complementary intervention that should be implemented together with preventive chemotherapy, mass drug administration in order to decrease transmission rate. And there are several documents which have been developed also on mobility management and so on in order to provide a full package of norms that can support programs towards the achievement of their goals. But an important missing point is the need to establish a verification process. So we probably will be based largely on what has been done for onco, in the past, and perhaps with some suggestions from the Guinea World Disease Program, which is an eradication program, so even more ambitious than that. So there's a need to put in place a validation process or verification based on the objective, the terminology changes, in order to be able to say that the country has achieved elimination or not. And this is the challenge of the next years. Onchocerciasis, another disease which is slated for elimination in Americas, probably will be also slated for elimination in Africa and in the Eastern Mediterranean, Yemen, Sudan, in the future. I have to say that the program is going very, very well in the Americas. You know, the programs are regionalized, so they're not managed by WHO in Geneva. They're regionalized, so we have OEPA, the Onchocerciasis Elimination Program in America. This is based in Guatemala for the 6 countries in the Americas that are aware endemic for onchocerciasis, and then we have APOC in Africa. So in OEPA, in the Americas, the situation is very good. 2 countries which have let's say one country has been verified as having complied with elimination, which is Colombia. It was the first country in the world to be verified as compliant with the WHO set targets that were developed in 2001. Then a second country, which is Ecuador, that was verified this year, and the decision is pending. The letter, the dossier, the report of the international verification team has been submitted. It has not reached Geneva yet. But hopefully in the next upcoming months, it will be, the country will be officially declared as free from onchocerciasis. Then we have 2 more countries where treatment has been stopped. They are under post-MDA surveillance, which are Guatemala and Mexico, and 2 countries which are Venezuela and Brazil, where treatment is still ongoing. We're talking about indigenous communities in the Amazon forest, so it's quite complex to reach them and to provide treatment to them in order to interrupt transmission. Yemen, I am not going to say, I already said that the program is trying to piggyback on the successful schistosomiasis one. There's another country, Yemen, which is Sudan. They managed to interrupt transmission in one focus. Now they are working towards interruption in the other side. APOC in Africa, for the time being, is controlled. Some countries have declared they have eliminated onchocerciasis, but they have not been verified yet. And then, of course, one of the issues of the upcoming months will be the transformation of APOC into something bigger and larger that perhaps will not focus only on onchocerciasis, but on other diseases in the African region. The new version of the guidelines is being developed and hopefully will be ready by the end of the year. It's the manual that provides information on what the country should do in order, what are the criteria that should be respected or complied with if a country wants to be considered as having eliminated onchocerciasis. So schistosomiasis, Alan has been talking about it. The latest news, let's say, is the shift from control of mobility to interruption of transmission. It seems possible, at least for some forms of the disease, mainly hematobium. Less likely, perhaps, for the zoonotic forms of the Asian schistosomiasis, but for the time, the norms are there. So there are several initiatives which are supporting countries to eliminate schistosomiasis. Some countries have been assessed, even though as the same as for LF, the verification system is not in place yet, and we have to be developed together with the one for LF in order to ensure that all the norms are there and countries can be declared as free of schistosomiasis. STH, the only disease that is targeted for the time being for control, so a less ambitious goal, just controlling morbidity, not focusing on interruption of transmission. The main indicator, as for the rest of preventive chemotherapy, as I will show you in a minute, is coverage, and the coverage is going up well for school-age children. Again, we have the large-scale donation of albendazole and mebendazole to treat school-age children in all endemic countries. The coverage in preschool age children, which is children below 5, and specifically for STH, the eligible population is from 2 to 4 years, is currently declining. It was mainly UNICEF that was supporting this type of intervention in conjunction with micronutrient supplementation or immunization activities. Unfortunately, the lack of a focal point for this disease in UNICEF New York has entailed that the activities are a bit scattered here and there based on the willingness of the national focal point, national heads of UNICEF offices to go towards that. Of course, we also have to say that there's no significant large-scale donation of medicines to treat preschool-age children for STH, so of course this also has an implication in terms of coverage. There are several models which are going to be developed in order to support implementation, and apparently there's now a new interest on the worming by a group of partners that are willing to invest into these diseases. It's probably the most prevalent disease worldwide, not only the most prevalent communicable disease or the most prevalent neglected disease, the most prevalent disease worldwide. Of course. Trachoma is the last one. As you know, trachoma was not part of our department until recently. It was considered as it was with non-communicable disease. Now we have a new focal point for trachoma in our department that is coordinating all the efforts toward the elimination of trachoma as a public health problem. There's one country, Oman, that has been verified as compliant with the WHO criteria. A few more countries, 5 to 7, that have declared that they have complied with the ultimate intervention goals, and therefore the goal that was in the roadmap to have 10% of countries as compliant with the ultimate intervention goal by 2013 seems to be respected. So it seems we are on track with regards to trachoma elimination with what's included in the NTD roadmap. A very important thing is the global trachoma mapping project that is supported by a number of partners. It's a partnership, in fact, that is aims at completing baseline mapping worldwide by mid next year, so that then all countries will be ready to decide whether they want to go ahead or not. But of course, they will have all the basic information will be ready to implement at least. So now this is the last part, just 2 slides or 3. It's a global status of preventive chemotherapy. As I mentioned to you before, by preventive chemotherapy, we define the large-scale distribution of drugs to entire population groups at risk. Co-administration are also possible, where more than one disease is prevalent in a country or in an area within a country. So we have approximately 122 countries that we have 122 countries that require preventive chemotherapy for at least one disease, and 44 countries that were implementing TC for all diseases, which means that if more than one disease is prevalent, their activities were being implemented against all the diseases which are there. And then in 2012 we had 75 diseases which were implemented for at least one disease. So you see the number of people treated every year is in the region of 700 million. The absolute number decreased a bit in a while. I'm going to try to explain why. But the good thing is that a very large proportion of the population requiring treatment in fact lives in the 75 countries that have been targeted, which means that the major problem is not adding new countries, of course we need to, but it's mainly scaling up in those countries where something is already happening, which of course is easier in a way because it means that the infrastructure is already there, that some activities are already there, and we can piggyback on that, like the example of Yemen I was making before. Schistosomiasis is already in place, we can add, and condemnicity is a reality, so perhaps we can add on top of that distribution of ivermectin in addition to praziquantel. This is disease specific, just a few figures. So here you see the total that I was showing before, 700 million, which is of course is not simply the addition of the different number of people treated for each disease, because as I mentioned, we have a significant overlapping of population. So an individual might receive treatment for more than one disease, but of course it is counted as a one person. And you see that for each disease, the number of people treated is significant, even though we are below the goals, because you see that, for example, onchocercitis is the one with the highest coverage, is about 77%, LF 39%, STH 32%, schisto 14%, trachoma 20%, and preventive chemotherapy overall about 37%. So much is being done, as the figures show. Much is being done, but much more needs to be done in order to provide treatment to all those who require it. And this slide shows a bit why there was a slight decrease of about 15 million people treated in 2012 compared to 2011. These are the poor performing countries, and of course, the major problem is represented by LF, as you see, and by India in particular. So the major problem here is that the concentration of the population requiring treatment for lymphatic filariasis is so much concentrated in India, almost 70 or 80%, now I don't remember, of the global population, that if something happens in that country and there's a delay or of treatment or treatment activities cancelled and so on, as was the case unfortunately in 2012 because of elections and other things, then the whole coverage goes down. The whole coverage of LF goes down, and of course as a consequence of that, the whole coverage of preventive chemotherapy goes down. But there are also good examples of countries that are increasing their coverage year by year, and then in fact is a reality in many countries. Of course, very large countries have a significant impact. I mean, the trend of treatment in very large countries, India is one, Nigeria is another one, DRC, Ethiopia, have a significant impact on the overall performance of the program globally. This is my last slide, just to remind you, as Alan was saying, that all these programs are made possible largely by large-scale donations by pharmaceutical manufacturers directly to WHO, and for some other drugs, not directly to WHO, directly to countries. So those which are managed by us are daily carbamazine, donated by Eisai, albendazole for LF, and albendazole for XTH by GSK, albendazole by Johnson & Johnson, praziquantel by Merck Germany, and triclobendazole by Novartis in Basel. And you can see that the number of tablets donated every year has gone up, from 820 million in 2012 to 1 billion this year, and then last year, and then for this year about 1.3 million. To tell you that the number of donated tablets is going up. We need to make sure that drugs which are delivered to a country are distributed, because sometimes drugs expire on shelves. Unfortunately, it's reality. And we are trying really to improve planning at the country level, trying to increase support, trying to match the donation with the availability of funds from donors in order to ensure that whenever even a single tablet is shipped to a country, it's distributed to the target population. And I think that's all. Thank you.